Welcome to America's Heroes Group.
And welcome to America's Heroes Group, this time with our roundtable and our partner, the Hines VA Women's Health Care. Today is Saturday, June 17th, 2023. Tomorrow, June 18th, is Father's Day. Fathers out there, happy Father's Day to you. June is LGBTQ Pride and PTSD Awareness Month. Our host is Kelley. You heard him at the top of the hour. I'm Sean Claiborne, the co-host, Army National Guard veteran. Our executive producer is Glenda Smith. Our digital media producer is Ivan Ortega of Scouts Honor Production. Of course, Shakai is filling in today as our studio engineer. And our panelists, Dr. Lisette Rodriguez-Cabezas, can be with us today, but we do have Dr. Kate Colangelo. She is a licensed clinical psychologist, currently women's mental health coordinator at the Hines VA. How are you doing today?
Hi, good afternoon. Thanks so much for having me.
So you have been a licensed clinical psychologist working here in Illinois at the Hines VA since 2014. You currently serve as a women's mental health coordinator at Hines, but you focus on the development of gender-specific reproductive-focused treatment options for women veterans. What does that exactly mean?
Yeah, that's a great question. So we know that there's certainly a really important link between our reproductive health and our mental health. Particularly as women during those stages across our life cycle, there's a lot of connection between hormonal imbalances and changes that happen. And so this is an area within our VA healthcare system that often does not get a lot of attention because our women make up a smaller percentage of our healthcare patients. However, it's an important link because we recognize that women can often go through things that are specifically due and related to our health as identified women in the reproductive system that we have. So because we know that there's a significant connection and a link between our health and our mental health, this was an area that was really important to myself and the team that we have, which is wonderful here at Hines, to make sure that we have a really specialized and focused treatment for women veterans that is unique and above and beyond other reasons why veterans may seek mental health services in the VA.
So what ways can you describe to us how the mental and the reproductive health are linked? What are some of the ways it manifests itself?
Yeah, so I'll tell you a little bit about kind of maybe some of the conditions that we specialize in treating, and we'll kind of talk a little bit about where that link can happen. So we know first and foremost, it might be really common for people to think that reproductive health is just related to this perinatal period, which is during pregnancy and postpartum. I just was working with a colleague the other day who was actually talking about a women's wellness workshop that she created. And some of the middle-aged veterans that she was working with said they weren't really interested in the session on reproductive health because they said something along the lines of, oh, I'm past the point of being pregnant. It's not relevant for me. However, it's really important to think that reproductive health across the full lifespan, which is a pretty extensive time period. So for women, it's between the interval between menarche, which is the average onset of menstruation, which typically happens for girls around age 12, but can happen anywhere between ages 10 to 14, all the way up through menopause, which on average happens around age 51, but can also start anywhere in the 40s or 50s for women. I think it's also important as we're kind of talking about this just to be really mindful of inclusivity in the terms and the words that we are using. So we may refer often to women veterans as we're discussing our services today. However, we know gender is often not binary. It's not just male or female. And the expression of someone's gender identity is much more inclusive, including transgender, gender neutral, non-binary, pangender, agender, genderqueer, two-spirit, third gender, and other identities. So it's really important to be clear that we are referring to persons who have female reproductive health systems, which is not only limited to those that identify as female specifically.
So has that led to any challenges when you're in the medical field? Because a lot of people have been debating about this because of the fact that when people outside the LGBTQ community who are just traditionally thinking about male versus female as simply a binary definition as your organ, not necessarily an identity per se.
Sure.
Does that cause any challenges when you're trying to treat people?
No. So what's important to us is that we identify persons that have those reproductive health systems that are likely to be impacted by the cycles that they might be going through. So things like menopause. Someone who is going through kind of the last of their menarche and is having kind of a stoppage of those systems, we know that the hormones in place at those times are likely to have a big impact. So regardless of necessarily gender identity at those times, it can often be most important to recognize the physiological structures within one's body that might be giving difficulties related to that. So for example, if someone might identify as a trans male, however, they still have female health reproductive systems, we want to make sure that because of those hormonal imbalances and changes that are happening at that time, we're addressing that specifically. So really we want to take kind of that intersection of where someone's gender identity and have certainly a respect and a place for that, as well as biologically what their body is going through and the type of support that we can provide within the VA system.
Okay. So tell us also, too, how unique is women's reproductive health and in your program? How unique is your program to treating women's reproductive health in the VA system? Do all VAs have this? And how does it compare to what you might see in the civilian world?
Yeah, so not all these have this, although I am fortunate to be part of a wonderful network of women's mental health champions that are across the VA. So there's a women's mental health champion at every single VA system. The national program has worked really hard over the last couple of years to set up champions there who really are there to pilot new programs and services, and reproductive women's mental health specifically has been on their radar for a little while. We actually have a medical director, a women's reproductive medical director within our national program, who was previously a psychiatrist here with us at Hines, who I know very well, Dr. Laura Miller. So we know that she is kind of leading that field and making this a big part of the VA services. So I believe it's something that's in development for many different places. However, how you provide those level of services might look very different. There's a saying out there that if you've been to one VA, you've been to one VA, because what they offer and how they offer it certainly differs. But I can tell you a little bit about kind of what that looks like within our clinic. So we refer to our clinic as providing specialty services for a very important reason. One, we want to make sure that we're recognizing kind of this unique gender-specific experience that women veterans may present to that might highlight the need for specialized treatment compared to those that identify as male patients. And it's particularly important if we really take a look at the population of women veterans for a second. So I like statistics. I'm going to throw a little bit of statistics out here. So women account for roughly about 10% of the veteran population. And the total population of women veterans across the next decade is estimated to increase by average about 18,000 women per year. And the number of women veterans that actually seek VA healthcare services has tripled in the last 20 years. So there's approximately about 500,000 women who are enrolled in VA healthcare systems, and they make up about 30% of all new patients that are enrolling in the VA. And of those, if we look at kind of the population within women veterans, about 2/3 of them are under the age of 55. And we know that general reproductive ages between the ages of about 18 and 44, that represents about 42% of women. So this is really the fastest growing group of VA healthcare services and consumers. And so even though we know that these reproductive milestones are natural biological processes, they can unfortunately really cause difficulty in impacting kind of that physical health and the mental health risks that we talk about. So our team specifically is really comprised of specialty trained psychiatrists, psychologists, peer support specialists. We work with our maternity care coordinator very closely, social workers, and then also trainees who are trained to focus on this intersection between reproductive health and mental health conditions, including depression and anxiety and PTSD. So our goal really is to provide a gender-sensitive assessment and interventions that really help our women veterans achieve their recovery goals and improve their wellness by managing the impact of these reproductive health events, which I haven't told you yet about, but I will in a minute when we get there to talk about kind of the conditions that we treat.
So for people who have female reproductive sex organs, do you see a difference between in or challenges between younger people versus older people? How does that change over their life cycle?
Yeah, so I would say, there's a common misconception that when we think about reproductive health, people only think about that perinatal period, as I was talking about earlier. However, it really is kind of the range across the life cycle. So let me kind of give you some of the common areas that we might focus on, and you'll see kind of how widespread across this life cycle that it can be. So a lot of times we'll work with patients that come in anywhere from premenstrual mood changes. So this is where there's an onset of physical, emotional, or behavioral symptoms. that typically occur in the last week of the luteal phase, which is about 1 to 2 weeks before menstruation. And so that's for anyone who is currently having a period. And we know there's often a premenstrual mood exacerbation. And specifically, we might treat a disorder that's called premenstrual dysphoric disorder, or PMDD. We might work with individuals who are coming in that are trying to have some family planning decisions. And so there might be some distress related to preconception and decisional strains between themselves and their partner. They might also have consultation questions for a psychiatrist with medications or different treatment options. We also work with individuals who are making contraceptive choices. So what birth control method do I choose to go on, and what's the interaction with the psychiatric medications that they might be taking? We work with women who have experienced infertility distress and the mood changes that are subsequent to that, whether that includes reactions to the procedures, the treatments, the invisible loss that they might actually be experiencing because of the hopes and the desires for parenthood that might be taken away due to those infertility struggles. We work with women during the perinatal period, so that's during pregnancy and up to 1 year postpartum. Our psychiatrists work on medication and treatment options, what is safe in order to take during pregnancy and while breastfeeding. We work with women who've experienced reproductive trauma. So this can be things like pregnancy loss, which includes miscarriage, pregnancy terminations, complications during labor and delivery that can be identified as traumatic. We also work with women who experience perimenopause. So there's a lot of mood disruption around that time, which includes some of the vasomotor symptoms, which are hot flashes, and night sweats, which are understandably really uncomfortable for women, and then also the experience of mood changes, so increased irritability, depression, and sadness. So as you can see, we work with a lot of different areas across kind of that full life cycle. So the experience might be different in what someone's going through depending on that life stage. However, we approach care in a very similar way and really trying to understand their reproductive health, what's going on with that event, how that's interfacing with their mental health, whether it's increasing anxiety or depression, sleep-related concerns, disordered eating that can happen during these times, or substance use to cope with the stressors that are going on, and giving them some good options for treatment and care that we can provide in order to help them work on the recovery related to that.
Mm-hmm. So how do people get in touch with the Women's Clinic? How do you reach out and get into the community and make people more aware? And particularly, and I'm glad you talked about the life cycle, because a lot of veterans, or our veteran population in general, is aging. So the majority of our veterans are seniors. And so you have a lot of senior women who are maybe going through menopause or maybe have gone through menopause. I'm curious about how that their military experience, particularly if they've been deployed, how that affects that psychological aspect, the mental aspect of their reproductive health, and how they're going through these different life changes in their bodies and so on.
Yeah, absolutely. So we notice within our veteran population that many of the patients that we see within our clinic are not just going through this reproductive life event and are subsequently having an experience of an increase in mental health concerns like anxiety and depression. Most often, these are comorbid with pre-existing concerns. And actually, those pre-existing concerns put them at a higher risk for experiencing some of the mental health impacts.
Not to interrupt you, but when you say comorbid, explain that a little bit for people that aren't in the medical field.
Yeah, thank you for catching me on that one. That's an important one. Sometimes I catch myself with that jargon. It's good to make sure we're clear on that. So when we think about comorbid, that means that someone is diagnosed with more than one mental health disorder at the same time. So for example, someone who might experience major depressive disorder, which is periods of ups and downs with their moods that last at least for a 2-week period and can sometimes last up to months. Or even a year or so for individuals. And so they might be experiencing those moments of depression. And on top of that, someone might also have a diagnosis of PTSD, where they're having recurring memories or dreams or images of a trauma that they might have experienced, whether in childhood or in the military or after the military. And that creates a lot of arousal, right? So being more alert, more on guard, more irritable, and so forth. And so when we say that, what I mean is that a lot of the women that we might be coming in might have anxiety or depression related to that reproductive health event that they're going through. So let's say during pregnancy. However, they might also have the existence of a predated medical condition or a psychiatric condition. So someone might have PTSD prior to that. they get pregnant. It's a very stressful time, understandably so, and so they're actually at higher risk for development of those conditions at that time because of that vulnerability. There's actually in a woman's life, for her physical health and her mental health, there is no more vulnerable period during that perinatal period. So during pregnancy and after, due to the risk both of on our physical health and then also on our mental health and our well-being.
So in the women's
it's
clinic,
really important to get connected, during these times.
Yeah. So does a women's clinic, to be clear, do they? So
Mm-hmm.
you guys have both gynecologists and psychologists working together?
Yeah, that's a great question. So if we think about the range of services that we offer, our clinic specifically is an outpatient mental health clinic. So what that means is that we are kind of housed within our main mental health building at the Hines VA. And I can tell a little bit about the types of services that we have specifically related to psychiatry and therapy. What you're asking about is what we have within our women's health clinic, which is a primary care clinic. And in that primary care clinic, we have general PCPs, of course. We have gynecology that's available for our women veterans, and we have what we call co-located mental health clinicians. So we call them primary care behavioral health. So there's social workers and psychologists that are located right within that women's clinic that can do warm handoffs. If a veteran's coming in distressed related to perhaps maybe the exam or the appointment that they have, they might be able to get in touch with that social worker or that psychologist. And then often they might do some short-term treatment and then refer more to kind of the longer-term or the outpatient treatment programs that are available within our mental health service line.
So once again, how do people get in front of you? So people, are they referred mostly from the women's clinic over to you guys to kind of get, and what are some of the things that might trigger a referral to you guys?
Yep, that's a great question. So, yes, part of our team is actually comprised of the providers that are in that primary care clinic, so our mental health providers. So they might often make those referrals. They see someone for a few sessions, recognize, typically they might keep someone if it's like a mild to moderate case, but someone that might be presenting with more moderate to severe symptoms is a better fit for more of our outpatient programs, which can be a little bit longer in the length of care that we can provide for them. And so our clinicians that are in our primary care unit might refer then to us. We get a lot of referrals actually just from our mental health intake center. So women veterans who might be just accessing the VA system for the very first time. We have a number of veterans who might recognize, hey, I'm really stressed out, having a difficult time with this pregnancy, and so I need to ask for help. And they might come in just through kind of that frontline treatment approach through the intake center, and then they get referred to us as kind of that specialty clinic where we can work with them. We also have our psychiatry work with our general mental health clinic as well. And so if someone experiences a reproductive health event during that time, they might already be seeing them for medication, so they might only refer to therapy. So we've got a range of different services. So our psychiatrists specifically, they can assist with one-time consultations or multiple visits to really meet the best needs of our women veterans. So they might have a one-time consultation, for example, if the person is currently working with a psychiatrist that's not a reproductive psychiatrist, maybe they are considering pregnant or kind of considering their options to become pregnant or currently are pregnant. They have some questions, some concerns about the medications that they're currently on, whether they go off that medication, which is unfortunately very common, which actually increases the risk of major depressive episodes during that time. So we know that many of the medications, especially SSRIs, which are a pretty standard depressive medication, are relatively safe. And so we want to make sure that someone who's knowledgeable about those medication options is having these discussions with our patients so they can come in for kind of that one-time consultation. And our psychologists also treat people kind of more long-term, whether it's med management during pregnancy up to postpartum and breastfeeding. Therapy, on the other hand, we can offer individual therapy services, and we really base it on an evidence-based, recovery-focused, and time-limited options to improve kind of mental health and reproductive health distress. And we typically take an approach of either cognitive behavioral therapy, which works on identifying the ways that emotions and thoughts and behaviors are all connected to the distress that someone might be experiencing, whether it's anxiety or whether it's depression. And so we make those connections and help them make changes. The other treatment that's most often used is called interpersonal psychotherapy, which is really about this bidirectional link between our mood and our relationship. So when we are not feeling good, whether it's because of anxiety or depression, it's very likely to have a negative impact on our relationships. And when we're not satisfied with our relationships, it's also likely to have a negative impact on our mood. And so we know a lot of these reproductive health events are often related to our partners or family members or the support that we have or that we don't have. So this can often be a really nice therapy to help boost social support and help improve relationships, to better manage the stress that someone might be experienced. We also do some trauma work.
Doctor, I got to cut you off because you ran out of time. We got about 10 seconds
okay.
left. Got to have you back to kind of go more into it because a lot of questions I want to ask you about, particularly when it pertains to, because LGBTQ Pride Month, when people go through transition, so they still have female reproductive organs, how does that complicate, or what are some of the challenges that are unique to that group of people? So thank you for your time. Dr. Kate Colangelo is a licensed clinical psychologist here in Illinois at the Edward Hines VA. This is America's Heroes Group.
Thank you so much.
We'll be right back.